A very good evening to all of you. As we, as chest physicians, we often come across scenarios where we are unable to classify our patients whether they are actually having problems or they are malingering them, they are feigning them. It can be a conscious response also, and it can be a subconscious response also. So at times it is also situational. It is very difficult for us as chest physicians to understand at times that the patient which is presenting to us with dyspnea, coughing, what is he actually suffering from, and how to alleviate his symptoms. After completing our protocol of evaluation, we often understand that this is not a physical or a respiratory thing. This is more to do with a psychological phenomena. So we then take the help of our psychiatric, neuropsychiatric, and psychological colleagues. At times, we even refer to our fellow clinicians like physicians and cardiologists for understanding this particular problem better. So, in order to understand with the help of several common case scenarios, these are all common actual case scenarios which we see in our OPDs. We will today on the platform of CCI try to discuss this very, very relevant and interesting topic with all of you. For this particular discussion, I have a very, very elite panel with us today. I have respected Dr. Surya sir from Lucknow. I have Dr. Mahesh Babu sir, who is a senior psychiatrist from Davangere. I have a few young Turks like Dr. Govind Desai from Hubballi, who is an interventional pulmonologist there. I have Dr. Utkarsh Gupta from Max, Delhi, who is a consultant pulmonologist over there. And I have Dr. Nazia Nousheen from Hyderabad, who is joining us. And she is recently back from her Hajj trip. So welcome back, ma'am. And thanks for joining us at such a short notice. So I would like to begin our presentation by our discussion today by a presentation from Dr. Govind, who will be highlighting on the protocol-based approach to these several symptoms. So over to you, Dr. Govind.
So good evening, everyone. I am Dr. Govind Desai. I am a consultant interventional pulmonologist working at HCG Suchirayu Hospital, Hubballi. So today we have a very interesting webinar, and the topic of this webinar is how to understand and classify respiratory symptoms during palpitation, malingering, etc. before labeling them as so-called psychiatric or functional. So I believe is noting anyone as a functional disorder is a very tough task, as it is going to label them for a lifelong also. So always we have to differentiate whether the patient who is presenting with shortness of breath, cough, chest pain, palpitations, exactly whether are they being caused by a pulmonary, or is it extra-pulmonary? And once we have a thorough history, we have a thorough evaluation, we have a thorough investigation analysis, then we have no answer. That's when we have to diagnose someone be having a functional disorder. This is quite common, specifically for young females whom we directly put up, a diagnosis of functional or so-called somatoform, sometimes even psychiatric disorder. So I'm going to basically discuss in the next 10 to 12 minutes about the extrapulmonary causes of respiratory symptoms, which we have to know. So before knowing that, what is dyspnea? So the American Thoracic Society defines dyspnea as a subjective experience of breathing discomfort. It consists of qualitatively distinct sensations that vary in intensity. It derives from an interaction of among multiple causes. It could be physiological, it could be psychological, it could be social and environmental factors, and may induce secondary physiological and behavioral responses. That's why dyspnea, we can see that the word psychological has been mentioned. So dyspnea is not always physiological. It can be because of a psychological factor, which is converting itself into a physiological symptom. That's how even the American Thoracic Society defines it. Now, grossly, the shortness of breath is differentiated as dyspnea due to disease of the respiratory system, which we most commonly deal with, dyspnea due to disease of the cardiovascular system, and dyspnea due to diseases outside the respiratory and cardiovascular symptoms, which are going to see in the next few slides. First, we'll see dyspnea mainly because of cardiovascular system. So we all know that the respiratory causes are quite commonly seen, and I think Dr. Utkarsh is going to discuss about it in the next presentation. I'm going to deal with the extrapulmonary, and the first most common cause of dyspnea, which we have to think, is the cardiovascular system. So we have to keep in mind the congestive heart failure. This is one of the most common symptoms as presenting as dyspnea, the disease presenting itself as dyspnea. Along with dyspnea, there are other symptoms. So always look for associated symptoms like fatigue, like diminished exercise tolerance. This can be easily been seen with a 6-minute walk test, which can be a differential of ILD. Also, further confirmed, we can go for a TMT, a Holter study. And fluid retention. So the signs of fluid retention can be as simple as pedal edema. So whenever we are going for a clinical examination, we should always come back to our MBBS, how we have found the general physical examination, the pallor, the icterus, cyanosis, clubbing, lymph nodes, as well as edema, right? So if we have a patient has a pedal edema and presenting with shortness of breath, look for involvement of cardiovascular system, mainly congestive heart failure. And that's why closely and thoroughly look for associated symptoms. We have the coronary heart disease, which is quite common among the old age and middle age population. Dyspnea can be because of coronary artery disease, even if not a classical symptom. It can present simultaneously with angina pectoris or as a predominant or a sole symptom of coronary artery disease, especially in patients with diabetic mellitus because of the diabetic neuropathy. So in diabetic patients, we can see dyspnea as the predominant symptom, and very rarely the patient presents with a chest pain. So such patients do suspect coronary artery disease and do evaluate for that. History, particularly the timing and the onset of dyspnea, mainly the stress, cold, often suggests that coronary artery disease can be a potential cause. Now, the assessment also includes conventional ergometry as well as stress tests, which we have discussed, the combination with imaging studies such that the X-ray comes out to be normal, the CT scan comes out to be normal, but ECG is abnormal. So that's an indicator. Always go for a 2D echo in such patients, and in centers where the facility of myocardial perfusion scintigraphy is available, stress magnetic resonance tomography is available. We should always go for it so that we come to a diagnosis of coronary artery disease. And ultimately, the best test to be done for a coronary artery disease to diagnose it is angiography. So it has to be done always when you suspect dyspnea and when the other findings are quite unlikely. The suggestive findings should always be followed by a cardiac catheterization, as explained. Valvular heart disease are also very common. These are quite common in our country because of the history of rheumatic heart disease in young people, which might present later in the stage with the aortic valvular stenosis or the mitral insufficiencies. Typical findings of aortic valvular stenosis includes not just dyspnea, they also have a diminished physical performance, episodes of collapse, syncope, dizziness, and sometimes chest pain resembling angina pectoris. Normally, the ECG in such patients reveal atrial fibrillation due to volume overload. And always, echocardiography is quite a distinctive and a definitive test for the diagnosis of a valvular heart disease. So keep in mind the coronary artery diseases, the congestive heart failure, and the valvular heart disease, which can also cause shortness of breath in such patients who come to your OPD, and not just the pulmonary causes. So what I mean in this slide is very important. We always try to auscultate the lung fields, and it is very important to auscultate the heart because murmurs can be felt quite simply and heard easily. pH, in certain cases of pH, we can have a loud P2. That is also quite easily seen. And always look for the JVP, which can also be an indicator of a right heart involvement. So now that we have discussed about the dyspnea due to diseases of the cardiovascular system, let us see diseases outside the respiratory and cardiovascular system. So anemia is one of the most common things which we see in Indian population. So it is defined that any patient who has a hemoglobin of 11, normally the WHO defines anemia as in males of less than 13 and in females less than 12. But any patient who has a hemoglobin of less than 11 grams, do try to find out what is the cause of anemia in such patients, as well as try to treat anemia particularly because in such patients who are having anemia, so I have seen a lot of patients who are COPD patients or who are asthmatics who come to my OPD, bronchiectasis, because of their malnourishment. They come and we treat bronchiectasis, but even if you don't treat the anemia proper, then the patient is not going to be better. He's going to come back to you with symptoms of breathlessness persisting. So always rule out. But also remember that there is no sharp threshold level. It has been said that if you have a hemoglobin of 7, you're going to be breathless. So it is quite subjective. A patient can be having a hemoglobin of 10 and can be breathless, and a patient can be of hemoglobin 7 or 6 and yet cannot be breathless. So it is quite subjective. So all patients with less than 11, do evaluate them. Diseases of the upper respiratory tract, ear, nose, and throat. in disturbances of the upper airways, the main symptom other than dyspnea is stridor. So always look for the symptom of stridor. And in PFTs, we can have the perfect box-like changes which can be seen. So rule of thumb states that dyspnea arises when the tidal volume is reduced by 30% of the actual value. So the actual value can be somewhere around 500 to 800. So anything below that 30% of that value normally is when the dyspnea arises. Also, one of the most common causes of dyspnea is neuromuscular diseases. So neuromuscular disease like Duchenne muscular dystrophy, which is quite evident, we can see the patient and we can diagnose DMDs, myasthenia gravis, motor neuron diseases such as AML and GBS. In such cases, it's quite easy to differentiate. But in cases of males or females who are coming with severe wasting, always remember that the breathlessness could actually be because of the muscle wasting. In most of these cases, the disease have other neurological manifestation aside from dyspnea. So always have a thorough CNS evaluation in such patients. And the diagnosis of such patients can be done by the PI max studies, the diaphragmatic muscle studies, as well as the muscle potential studies which can be done. So these are classically done. But if we have a DLC or if we have a lung volume study, we can get to a diagnosis of neuromuscular disease in such patients also. Also, not the last one, but it is very important that a patient's history, a thorough history of medication should be taken. Non-selective beta blockers can cause bronchospasm via the B2 blocking effectivity. So this is quite common. A patient comes to us, you have treated everything, you have ruled out everything, the X-ray fine, the CT is fine, and yet the patient is breathless. And then you take a history further, you come to know that the patient was taking atenolol. And by stopping atenolol, the patient's bronchospasm episodes have relieved. NSAIDs are also known to cause quite a lot of time bronchospasm because of the mechanism which I've mentioned here, that is a cyclooxygenase 1 inhibition leading to excessive production of lipooxygenase and leukotriene. So this can cause bronchoconstriction. Also, this is a very important point which I found it in one of my literature study called as Plato, which was done, showed that ticagrelor is also associated with dyspnea in around 15% of the cases. And this effect is probably mediated by an inhibition of adenosine receptors. So any patient who is on ticagrelor coming with breathlessness, always look into the fact that other than the cardiovascular cause, the patient could be actually having breathlessness because of the medication itself. So these are few things which I wanted to tell. What it basically means is always look into the associated history of palpitations, chest pain, whether the patient is having hoarseness of voice, whether the patient is having pedal edema, whether the patient is having the paradoxical pulse, whether there is a wheeze, whether there is orthopnea, which we normally miss. So all such cases will actually help you to know that actually the cause of breathlessness is not the respiratory and it is the cardiovascular system. It could be the anemia in case of hemic murmurs, in case of marked pallor, marked anemia. Always rule out that the patient is having anemia first. And in cases of cardiovascular auscultation, you can actually get to a diagnosis of a murmur, and that further leads to a diagnosis of an aortic insufficiency or a mitral stenosis. So once we have covered breathlessness, which is the most common symptom, extrapulmonary cause of a breathlessness, let us go to cough. So the cough is defined as a sudden explosive forcing of air through the glottis to expel mucus or other materials from the tracheobronchial tree. Again, cough can be because of multiple causes. Normally we define cough as acute, that is less than 3 weeks, and more than 8 weeks we define it as a chronic cough. Sometimes some authors also use a definition of subacute cough to differentiate from 3 weeks to 8 weeks. So in cases of acute cough, it is quite simple because most of the time the cause of cough can either be a upper respiratory tract symptoms or it can be a lower respiratory tract. So it can be that the patient is most probably having a acute rhinosinusitis, the patient might be having GERD. So these are the certain symptoms which we need to know. But most commonly, the danger signs of cough, which are other than that of a pulmonary, which I have mentioned here, could be a foreign body, which could be either lodged into the upper airways. It could be because of a pneumothorax, which is again a pulmonary cause. So these all findings have to be understood and known. There are cardiovascular diseases who might also present with acute cough. So always look into the cardiovascular component, the upper respiratory component. It could be an obstruction. It could be a foreign body lodged into the upper airways, as I've discussed. It could be acute laryngeotracheal bronchitis. So all these causes are upper respiratory and they have to be seen before putting the, getting an X-ray and ordering an X-ray and and informing the patient that the X-ray is normal. So there's no need to do anything. So frequent causes, as I've mentioned, it could be the upper respiratory. Acute left heart failure with congestion is one of the disease or the cause of acute cough. And in COPD, it can be in acute exacerbation. The patient is coming to you, you don't have a history in the background. And while taking the history, you might get to know that he's actually a COPD present with acute exacerbation. It could be because of acute adverse drug effects also. Upper airway cough syndrome, postnasal drip, as we have discussed, are also a quite common cause of acute cough. Chronic cough. So any cough lasting for more than 8 weeks affects approximately 10% of the population. And I think the cause of this, the numbers might actually be quite higher. And it is one of the most common reason for outpatient medical consultation. So these are most commonly causes of a chronic cough. It could be that the cough is because of a hypersensitivity to fragrances, cold in case of asthma. But also, mind you, that it could be because of a heart disease. It could be because of pre-existing neurological condition. Probably that patient is constantly been having a history of aspiration. So I have seen 2 or 3 patients who actually have presented to me with being coming as a chronic cough, and then taking on the history, they have given a history of old CVA, and that's when you evaluate and see that probably the patient might be having recurrent aspirations. One of the best way to understand and diagnose this study is also a gastrographin study, and history, as I said, is the most important thing. Also, there are certain drugs, ACE inhibitor, which we commonly know are one of the reasons of chronic cough, because ACE inhibitors don't start presenting with cough by the accumulation of bradykinin in the first few days. Normally, the presentation is in weeks to months. So always take a history of that. There is a specific history findings of pulmonary toxicity because of cytotoxic agents. Amiodarone is one of the most common drug, which is also known to cause chronic cough. GERD is again a very common cause. So we see in the right side of your column, the extra-pulmonary causes of chronic cough, which have to be ruled out before labeling the patient to be having so-called functional or psychological, is upper airway cough syndrome, inducible laryngeal obstruction, gastroesophageal reflux disease, drugs like ACE inhibitors. Cough of unexplained origin could be because of these findings. It could be chronic left heart failure leading to patient having episodes of edema. And most importantly is the mediastinum. Never forget the mediastinum. It could be just a large lymph node which is compressing the airways and causing patient to cough. So always get a CECT or a CT thorax at a better institutes and see whether there's any actual lymph node at different stations causing compression of this. Because if that is there, then you have to further evaluate the cause of chronic cough in such because of an unexplained mediastinal lymphadenopathy. It could be a esophageal diverticulum. Ask for a history of particularly having a cough after drinking water. If that is there, most probably the cause is a tracheoesophageal fistula or a esophageal diverticula, which is compressing the trachea. So this is also very important. So what I mean to say, even in cases of cough, is rule out cardiac causes, rule out musculoskeletal causes, which are most commonly associated with breathlessness, cough. The two most common associated symptoms in before diagnosing someone as a functional. Chest pain also is one of the cause. In chest pain, always rule out cardiac. And second thing, musculoskeletal causes like teeth syndrome could be a cause of that. Hemoptysis is very rarely seen and it could be a cause of malingering. But before defining someone as malingering, malingering is a legal concept. It should be left to the honorable court to label someone as malingering. We can only give adjunct tests which should be done. So with that, my take-home message basically for this presentation is that a thorough clinical acumen, history taking, clinical examination, and relevant investigations are very necessary before labeling a patient as functional. I would like to thank the Chess Council of India for giving me this opportunity, and let us have the question and answer sessions after Dr. Utkarsh's presentation. Thank you so much.
Hi everyone. Good evening. I am Dr. Utkarsh Gupta, working as attending consultant at Max Hospital, Vaishali. Firstly, I would like to thank CCI for giving me opportunity to speak on this platform. I will be briefly highlighting the approach we should keep when a patient visits to us with a respiratory symptoms. So I'll be taking up two case scenarios where a patient one is an 18-year-old female who visits emergency department with sudden episodic shortness of breath ghabrahat, giddiness, severe fatigue, and finger spasms. Her mother gives history of similar on and off episodes in past 3 months. She has CUET exam scheduled after 7 days. There is no other significant medical history. She is unable to stand or sit properly. Fingers have carpopetal spasm. There is tachycardia with a pulse of 104 per minute. Blood pressure saturation is normal. Respiration is 38 per minute with forceful, rapid, and deep breathing. There is no other significant finding on examination. Systemic examination is normal. Another patient is a 48-year-old female who presents to OPD with dyspnea, chest pain, palpitations, tremors, and sweating. This is the second event in past 1 month. She has a history of untimely death of her son in RTA 3 months back. There is no other comorbid illness, no significant medical history. She is anxious on examination and is unable to speak complete sentences. The pulse rate is 120 per minute with a blood pressure raised 160 by 84 mmHg and respiratory rate 32 per minute. Other examination findings are not. The patient was shifted to ER for further evaluations. Now we will be taking these two patients at the end after we look at the approach, how we progress with these patients. So generally, any patient who comes to us, we first go with a detailed history, asking for the cardinal respiratory symptoms, including dyspnea, cough, expectoration, hemoptysis, chest pain, fever sometimes. Then we look for the physical examination, including vitals, pallor, icterus, clubbing, respiratory system in detail, and then a short about the other systemic examinations. Diagnostic investigations include X-ray, ECG, APG, chest X-ray as and when it is suitable. We go for another treatment options like whatever is required as per the patient's need. Coming on to dyspnea, first and the foremost is the onset of dyspnea, whether it is acute or chronic, followed by position, whether it is associated with orthopnea, platypnea, paroxysmal nocturnal dyspnea, trepopneas, whether the dyspnea onset is nocturnal or postprandial. Each and every detail is important because they have different differentials and many of them. Then grading, we guys usually use MMRC or NYHA classifications. There are others as mentioned here. We then go for precipitating factors like exercise, exposure to smoke, allergens, occupational history. We ask for a severe weight loss history, whether the patient is obese, what are the relieving factors that relieves the dyspnea. We also ask for the past history, drug history, smoking history, and the personal history, whether the patient is anxious, have anxiety attacks, panic attacks, or about the recent stresses. Coming on to cough. Cough, again, the onset is very important, whether it is acute, that is less than 2 weeks, it is subacute 2 to 8 weeks, or it is chronic cough, which is more than 8 weeks. Type of cough is also important, whether it is dry cough, it is productive cough, or a brassy cough, bovine cough, or whooping cough, whether these are very few in number, but yes, whenever we find it, they are the short differentials. We also look for the associative factors, whether the cough is associated with fever, as we see in ongoing infections, shortness of breath, and respiratory distress. Patient is associated with wheeze and cough is asthma, COPDs, with chest pain, pleuritis, chest wall diseases other than the cardiac DDs also. Hemoptysis, loss of appetite, loss of weight will include the first DD in India will be tuberculosis, obviously. Associated with dyspepsias, heartburn, it would be GERD. Any medication history, which should be ACE inhibitors. Nocturnal cough would be bronchial asthma, GERD. Postural associated with respiratory diseases, occupational pneumoconiosis, etc. Coming on to expectoration, one of the most important thing is we all should always quantify the amount of expectoration. Whether the sputum is minimal, it is moderate in amount, or it is large like bronchorias more than 100 ml. Quality of the sputum, whether it is serous, it is mucoid, or it is purulent. And then we have to go for the color, whether it is white, yellow, rusty, green, pink, red, gray, or black. Then coming on to hemopsis, we all know in detail how to what hemopsis is all about. So whether it is, firstly we have to look for whether it is true, spurious or pseudo hemopsis. Then the amount of hemopsis, mild, moderate or massive. According to this, we go on to how our approach depends upon the mild, moderate and severe grading. Then the source of bleeding, whether it is tracheobronchial, it is lung parenchyma, vascular, or it is any trauma or any other miscellaneous causes like blood coagulation defects, like catamenial hemopsis. Then we have to look whether it is associated with uh, according to the age, less than 40 years, more than 40 years, whether it is associated with cigarette, asbestos exposure, or the color of the hemopsis and the smell of the hemopsis, that all makes different differentials. Lastly, I'll be coming on to palpitations. So also looking at the palpitation, it's not a normal respiratory symptom, but because our topic mandates it, so I'm discussing this also. So palpitation, whether it is continuous or intermittent, we have to look for heartbeat, whether it is regular or irregular, what is the current heart rate, then whether the attacks are discrete or they are abrupt onset with abrupt termination. Is there any history of structural heart disease like CAD, valvular abnormalities, and then whether it is associated with chest pain, fever, syncope, weight loss, anemias, polyurias. These are some common clinical findings that are associated with palpitation with the possible DDs. We can go through this later. Coming on to the examination parts, like we'll be discussing this in the four headings: vitals, palpitations, vitals, palpation, inspection, and auscultation. So some common examination findings that we usually find are accessory muscle use, nasal flaring, cyanosis, tachypnea, clubbing, nasal polyps, lymphadenopathies, stridor, pursed lip breathing, barrel-shaped chest, tracheal deviation, unilateral or contralateral, dullness on percussion, hyperresonant sounds, subcutaneous emphysemas, silent chest, crackles, wheeze, bronchial breathing. Then we look for the systemic findings, like in cardiovascular system, we look for malar flush, irregular pulses, raised JVPs, heart sound variations, murmurs, neurological findings like confusion, drowsy state, whether patient is having any cranial palsies, is there any ptosis. We look for the GI findings, including the enlarged abdominal veins, abdominal tenderness, any ascites or absent bowel signs. Then accordingly, we investigate the patient, lab investigations, routine investigations, CRP, ProCal, ProBNP, thyroid profile, lipid profile, serum profile, D-dimer, ANA profiles, rheumatoid in ILD exam, ILD investigations, and then we'll go for some specific total IG specific in EVPs and asthmas. Respiratory investigations go for chest X-ray, ABG, sputum analysis, PFT, DLCOs, HRCTs, CTPA, bronchoscopies, or other interventions. Cardiovascular, we look for ECG, echo, D-dimer, TROP-D, Holter monitoring, CT angiographies, and other symptom and system-specific investigations, ENT, like direct and indirect laryngoscopy, abdominal ultrasounds, esophageal manometries, endoscopies, whatever is necessitated in specific patients, we'll go for that. So, summarizing an approach to dyspnea, we'll go for a chest X-ray. If we find that chest X-ray is normal, we'll go for spirometry. If we find spirometry is also normal, we'll do the ABG. If we find that ABG, the PaO2 is more than 70, we'll measure the oxygen saturation. We'll find that that is also normal. We'll look for hematocrits, and if hematocrit is also normal, we'll perform the exercise PFT. Then if exercise PFTs are also normal, we are very much clear that the patient is normal, having no respiratory illnesses. So we say whether there is deconditioning, psychogenic dyspnea, hypermetabolic states. In other cases, we further investigate with the patient with the echo, VQ scans, whatever is necessitated to reach the diagnosis. Similarly, in chronic cough also, the first is detailed. After detailed history examination, we will look for if there is any abnormal findings, then we'll try to treat that patient with the initial medications. And if it is not, then we'll think about the chronic cough causes like upper airway cough syndrome, non-asthmatic eosinophilic bronchitis, gastroesophageal reflux disease. We'll try to manage these according to the optimal treatment. And if still the patient is suffering, then we'll go for further high-end investigations like pH monitoring, endoscopies, barium swallow, CT scans, bronchoscopies to reach the final diagnosis. This is a very detailed chart how to evaluate the chest discomfort or pain. So usually under 3 headings, we'll see this cardiovascular finding, pulmonary causes, and the other causes. And in the other causes, there comes the neurological chest pain that includes anxiety, herpes simplex virus, somatoform disorders, and spinal radiculopathies. Hemoptysis, we all know, mild, moderate, and massive. Massive, it is first medical emergency, so we have to secure the airways before we secure the airway. We have to stop the bleeding before we start to investigate for the cause. In mild and moderate, we first try to find the cause along with trying to secure and stop the hemoptysis. Coming on to palpitations, detailed history, physical examinations. Then we'll do ECG to look for any structural heart disease. Then if the palpitations are daily, then we will start the trans-telephonic event monitoring. If the palpitations are less than daily, we'll begin it after 2 weeks that if the repeated events are occurring. And if there is normal sinus rhythm, then we will reassure patient, consider panic disorders. And if there are ventricular arrhythmias, there could be non-ventricular arrhythmias, there could be structural heart diseases. We look for whatever is the app and treat accordingly. So the treatment options available are medications, oxygen therapy, pulmonary rehab, and other specific treatment according to the diagnosis, whatever the patient has. Coming back to our 2 patients, the first patient was an 18-year-old female and the second was a 48-year-old female. So the first patient, when we investigated her, all her investigations were normal other than the ABG, which had a pH of 7.28, PCO2 of 27, PO2 of 93 with bicarb levels of 22. Her echo was normal, ultrasound was normal. So patient was even given oxygen supplementation, IV steroids, nebulization, and they also gave a calcium gluconate injection on initial assessment by the ER team. When we approached the patient, we took a psychiatric consultation, revealed that patient is anxious and is feeling worthless for her upcoming exam. So patient's attendance was sent out by the psychiatrist. Oxygen was stopped. She was made to breathe with the oxygen closed in a closed face mask, and her breathing settled after 15 minutes. Psychiatrist came to the conclusion of a diagnosis of psychogenic hyperventilation after reassuring the patient, she was pretty fine and went back home. The second patient, who was 48-year-old female, she was also investigated. All investigations came out to be normal. Lab investigations were normal. ABG was also normal. We tried doing a PFT. She couldn't perform it very well. Then again, when the psychiatrist consult was taken, she revealed that she hadn't slept well in past 1 month. With a detailed counseling was done, along with he gave propranolol to the patient. She felt better after 1 hour. She was reassured, was sent home on medications including propranolol, paroxetine, and clonazepam. She was doing well, and even after 2 months, there was no repeated episode of any panic, any attack. So the diagnosis made was panic or anxiety attacks. That's all from my side. Thank you.
Well, thank you, Utkarsh, for that very elaborate presentation on the respiratory causes of psychogenic hyperventilation, dyspnea, and other causes. At the same time, a very well illustrated presentation in our previous presentation by Dr. Gupta, in which he also very well enumerated the separate extra pulmonary causes of psychogenic hyperventilation. Now, actually, we have our full panel today, in which we have an esteemed psychiatrist also. I would really give a hats off to Krishna sir, who went ahead with this topic and included all of us in this, because this is something I will say in a busy OPD. I think there are almost 3 or 5 patients which we see, in which we really think ki there is something which is not matching. At times we really are not able to associate their problems and the fact that they are not relieved with our symptoms and diagnosis with anything which is physiological. So at that point of time, we often feel that. So Govind is an interventional pulmonologist, but I am sure he also must be seeing such patients. There is that very characteristic case ki bronchoscopy kari aur uske baad se gale mein kuch chubh raha hai. Even that feeling goes on till 3 to 4 months. So this is a very, very strange situation we find caught up in after procedures. So coming back to the discussion at hand, I will now involve all of you with some 10 case scenarios, and all of these case scenarios are actual OPD setting case scenarios. There is no fabrication whatsoever. This is a very different sort of topic, so the presentation design is also a bit different. At times you might have queries ki yaar ye case mein ye ho sakta hai, wo ho sakta hai, but believe me, this was what we had at our hand, and we are trying to discuss this very pertinent topic. I hope we are able to capture the essence of this. So now, I would like to begin with Dr. Nazia. Dr. Nazia, you can hear me, na?
Yes, yes.
Yeah. So now we had a patient. This patient was diagnosed as a case of CA lung stage 1 some few years back. He was treated completely, declared disease free. And currently he comes back to us with shortness of breath and inability to sleep properly. This guy, he underwent a PET scan also, which was normal. He currently has come to us with the problem of shortness of breath, inability to sleep properly. He has again started to have a craving for tobacco and has restarted smoking. Recently, there has been some change in his family structure. His wife, having undergone a knee replacement, is on rehabilitation. So he is having to do more physical work than usual. This particular patient was treated initially with all the basic bronchodilators and underwent that PET CT, which was normal. But he keeps on coming back saying that his shortness of breath and inability to sleep is not resolving, and the smoking problem is coming back very, very strongly. So how would you work up this case if he comes in your pulmonology OPD?
Thank you, sir, for giving this case to me. It's a very, very typical case in which we are seeing a CA lung patient, and he has almost all treated and he has been declared normal. But when we see his history, that even after getting treated by bronchodilators and anti-shortness of breath medications, is coming back. And we typically see the craving for tobacco. This can be because of his psychological effects. And when there is his family history of his wife undergoing surgery and is having craving for this tobacco and all, this definitely shows his psychogenic status. And I want to see the patient. Maybe he can have other conditions like COPD, or he may be obese, having some OSA, or some maybe anemia because he's doing a lot of physical work, as we are seeing. Maybe he's anemic also, or maybe some hypertension which is causing his congestive heart failure. So after ruling out all these, definitely we have to look at his psychological status and what is causing his shortness of breath. That is more of a psychological shortness of breath. So how do I work up this case? I have to get the investigations first, look at his blood pressure and other investigation like CVP for his hemoglobin, and also his 2D echo to rule out any cardiac causes, and definitely a pulmonary function test to see if it is any case of COPD or any other ILD has set up here after getting treated with his anti-cancer drugs. And after concluding that he hasn't, there is no role of any lung pathology here or any other cardiac pathology, there is a role of psychiatrist to look up this case because he has a craving for tobacco. He might need this nicotinics and tablets, medications to stop his craving for. So after the workup of the investigations, only we'll be able to see for this case, and also we have to go for a sleep study to see any OSA component is there which is causing his shortness of breath and dyspnea and his disturbance of sleep. What he's saying here.
Right. So now most of these things which you told, like the PFT, the echo, and the sleep study were done, which eventually came out normal. And like you very correctly so told that this particular craving of his, even despite being a lung cancer survivor, was very abnormal. And despite all of our medication, he was actually having a very strong craving because of his familial circumstances. So in your routine practice, do you involve a psychiatrist in this sort of a case? Or you try to treat that smoking craving on your own?
Not exactly in a CA cancer patient, sir, but I do have patients who have a typical shortness of breath, who are not responding to medication, and definitely they have no pathology which is involving lung. Then I take an opinion of a psychiatrist, which shows sometimes they have panic attacks and some psychological disturbances which is causing the shortness of breath.
Right. So, respected Mahesh Babu, sir, I would like to involve you in this particular case. Dr. Nazia has worked her up perfectly. PET is normal, your echo is normal, your spirometry is normal. But this particular lung cancer survivor, he is not relenting on his smoking habits. He is smoking continuously, and he keeps on coming back to in our OPD telling ki shortness of breath, theek hi nahi ho raha hai, theek hi nahi ho raha hai. So, sir, any inputs from your side?
Yeah, thing is like here, like as a pulmonologist, you may be concerned about the CA lung and nicotine, that is, smoking as a problem. But for his shortness of breath and for his other problems, like he is under stress, that he was not doing domestic work earlier, and now he has had to do, his wife has undergone knee surgery. So stress can be, a situation can be stressful for different people on a different grading. So this person may be feeling the stress of those things, number one. And two, his smoking may be increased because of that also. And concomitantly with CA patients especially, we must always keep in mind depression. Because most CA patients, for various metabolic reasons, they may be having depression, a depressive symptom, as well as psychologically. I mean, it is not comforting to have a CA with us. CA, is it not? So I would look at it as the person having both depression and nicotine dependence. Dependence, again, we have to see whether he is really dependent or he is just using, or is it a harmful use. A dependency it is totally addiction. I mean, the number of smoking, cigarettes he's smoking, and various things like that. So here I would consider depression and the stress of his own CA, as well as the wife's knee surgery, these things.
Right. So I agree with you, sir. There are many more case scenarios. So depression is one such condition which we should think of in such a particular setting. Suryakant, sir, I would like a final comment from you on this particular scenario, that Dr. Nazia has worked her completely, but Dr. Mahesh Babu, sir, is strongly feeling that we should consider antidepressants and anti-smoking measures in this patient, sir. Your final take on this case, sir.
Dr. Ravi, can you hear me? Am I audible to everyone?
Yes, sir. You are audible, sir.
Okay. So, Dr. Ravi, thank you for my final comments. If you see this case scenario, the case is stage 1 lung cancer. So probably surgery has been done, because surgery is the choice of in stage 1. And of course, post-surgery, probably chemotherapy, radiotherapy, whatever, everything has been taken care, because the post-treatment PET scan is normal. So there is no possibility of any relapse of the lung cancer, number 1. Number 2, as this patient have been a smoker earlier also, and now again started smoking. So yes, there is a possibility of COPD. Yes, Dr. Nazia has rightly mentioned that we have to rule out COPD. Third thing, he is having a sleep problem also. If patient is not having obstructive sleep apnea, means he is not obese. So that possibility is also ruled out. So if the 3 situations they have been ruled out, and even if they're not ruled out, psychiatrist has to come into this picture, because he is having a strong addiction for the tobacco. And my dear friends, all who are logged in, the strongest addiction in the world is the tobacco. It is not the brown sugar, it is not the opium, it is not the alcohol, but it is the tobacco. So psychiatrist has to be come into the picture, because this patient has developed lung cancer. He knows that he developed cancer because of the smoking, and still he is smoking. So definitely he needs de-addiction, of course, by a competent psychiatrist. So I would, of course, by just ruling out the COPD and any obesity or sleep apnea, and then, of course, directly refer to the psychiatrist. And, of course, this is the era of specialization. So I think, yes, meanwhile, you can think of the depression or whatever it is. But I think the right thing would be, considering the all medical legal aspect, the behavior of the society, you see, so it is better to have an expert opinion. So I would definitely refer to the psychiatrist.
Right. Thank you, sir. Thank you. Now, coming to our second case scenario, Dr. Govind, I would like you to be involved with me in managing this young boy. This young boy comes to us in the OPD with his family, and he presents to us with complaints of severe chest pain and palpitations when he gets up in the morning. Interesting part of his history is he has been living in a boarding school hostel for 1 year, prior to which he was living at home. There is no other relevant past history. He comes from an affluent farmer's family. The parents who have come with him are very caring. On examination, this young boy is quite obese. He is having a congested nose. Because of the chest pain and the mismatch of symptoms, we underwent a CT pulmonary angiogram and 2D echo for him, which was perfectly normal. We did a PFT for him, which showed mild restriction, and the blood workup showed some vitamin D deficiency. Now, Govind, how would you like to work up this case further? Anything more?
Yes, sir. So here we see there's a 13-year-old boy presenting with severe chest pain and palpitations. And whenever we hear the word palpitation, the first thing we think the symptom being involved is the cardiovascular system. And fortunately or unfortunately, CT angiogram has been done, and angiogram has been done to rule out any embolism, or 2D echo is normal. So let us go from the history point of view. He has moved on to a hostel in the last 1 year. So there is one thing that there could be some dietary changes which could have led, could be an episode of GERD, which can be suspected in such case, where it is causing both the heartburn, presenting as a severe chest pain, and palpitations. Other than that, this patient who is obese, so there are two things which come in my mind, and this can be evaluated on a general physical examination. I would look to the, examine or palpate his neck, look for the thyroid gland, because probably it could be a hypothyroidism. There is a thyroid dysfunction, which could be presenting as, the patient is having this palpitations. Though hyperthyroidism is most commonly associated with palpitations, we have seen that patients with hypothyroidism are also known to have palpitations in around 10 to 30% of the cases.
Right.
Other than that,
no, I'll just add one important thing. This patient was actually referred to us by an endocrinologist who had worked his thyroid, parathyroid, and even calcium, and a lot of workup was already done. But this guy had such a strong problem of chest pain that they actually had to send it to the chest physician. Please carry on.
Okay, sir. So now that we have ruled out even the hypothyroidism problem, now one important thing which can be seen in this is, I would also evaluate this with the help of an ENT, because he's having some amount of nasal blockage. So is it that which is causing? Very unlikely to cause palpitation, a sinusitis, or a DNS. Yes, but I would take help of my ENT colleagues. Other than that, one important finding which has been seen is palpitation in the early morning. So yes, though childhood obstructive sleep apnea is very rare, a patient who is having severe chest pain and palpitations associated, and he is around 13-year-old, I would also like to rule out obstructive sleep apnea in this case. And CBC is not available in this, but if there is anemia, whether that is causing severe chest pain and palpitation, it's also something which I would rule out.
No, it was all normal. I agree with you. Now the $1,000,000 question: would you like to involve a psychiatrist in this particular case because of the vague and diffuse nature of symptoms?
Yes, sir. Maybe once I rule out obstructive sleep apnea in this case, and if that has come out to be normal, yes, I would really like to go for evaluating with a psychiatrist or taking help of a psychiatrist in this case, sir.
The sleep study of this particular patient is still pending. Next break from the hostel is in Diwali time, so maybe we'll be planning it at that point of time, or maybe at Rakhi. So Mahesh Babu sir, I would like to involve you. Suppose we do everything, we do all our workup in this particular young child who has presented to us. Would you like to add any input from your side, sir?
Yeah, definitely. I did history as Dr. Govind has reiterated, or Dr. Utkarsh also, they have taken adequate history. After all those things, supposing if the boy comes to me in an acute episode, I would of course rule out the medical or physical causes to this, and also think about the temporal relation of his shifting to the hostel and the development of these symptoms is very important again. And that separation from the family as well as the siblings, it adds to the anxiety and anxiety to the child. And also the adjustment issues that he may be having in the hostel with his peers and the teachers, new setup, the dietary changes, all these things add to the maladjustment of the child. So I tend to see such people, boys from the boarding school who refuse. They come to us with the school refusal, history of school refusal. For 1 month, they come for a holiday and they refuse to go. So then where we evaluate and these issues are adjustment issues are seen. And of course, before all these things, like as you people have investigated and then everything is normal, I think there is definitely a case to consider the psychological aspects in this child.
Mahesh Babu sir, I would just like to ask you a question. Are like as pulmonologists, sometimes we also are able to diagnose that this is anxiety disorder. What would you suggest, that should we go ahead and add an anxiolytic, or should we actually refer it to the psychiatrist straight away?
Yeah, you would be the best person to identify whether it is an organic dyspnea or like the breathing problems. You would definitely come to know on the face of it as the patient walks, the organicity of those things. But still, we cannot go on the face value and continue to do an examination. Adding an anxiolytic might, especially in children, we don't generally add anxiolytics, at least me as such. We need to reassure the child and the relatives, and only then, if you are really convinced about the non-organicity of the symptom, the reassurance itself will add a lot. And if the relatives insist on medications, only then you can go for a small dose of anxiolytics, and there is then maybe refer to a psychiatrist.
Right. So ultimately, Surya sir, I would like a final comment from you, sir. Is particular bachche ka kya kare, sir? What is the final verdict?
Yeah, Ravi, I think there are 4 definite organic type of involvements are there. So I will not jump directly to the psychiatric involvement or psychiatric referral. First thing is upper airway is involved in this case because nose is congesting, number 1. Number 2, patient is obese. So I think the obstructive sleep apnea is the possibility, as one of the panelists has already mentioned. Number 3, vitamin D deficiency is there. That may be cause of the chest pain. So I think we need to have a correction of the vitamin D. And number 4 is there is a strong possibility of GERD also, and that could lead to the palpitation. So I think the 4 things to be corrected first, and then only, of course, we can think of referral to the patient to the psychiatrist. If the patient, after all these correction or ruling out all these things, if patient is not responding, is still complaining of chest pain and palpitation, then of course this is the case of psychiatry.
Very nice. So I fully agree with you, sir. So not all situations which by first looking out we might feel that looks to be psychiatric, but a detailed evaluation and a very, very strong emphasis on the presenting features has to be given. A thorough physical examination needs to be done. Whether the the social setting might be guiding us to think it is psychiatric, but still, as pulmonologists, we have to evaluate it thoroughly. Now, Utkarsh, I would like you to join me in managing this particular newlywed bride. She presents to the OPD with recurrent breath holding episodes. She is having no past relevant medical history and recently has been on OCPs. Her echo, X-ray are advised and they have been found to be normal. She is reassured, advised rest and supportive treatment. But subsequently also she keeps on presenting to us in the OPD with similar episodes and is often accompanied by her friends as the husband is on tour. So Utkarsh, how would you work up this case further?
Initially, I would like to gather the detailed medical history about the breath holding spells, like how the event started, their onset, their pre-episodic illnesses, the frequency of the episode, the duration of the spell, any triggering or the precipitating factors like any stressors or the emotional events at the time when these spells occur. I would also like to know about any possible allergen exposure that the events occur after eating some kind of food or after exposure to the dust. Then I would like to inquire about her lifestyle factors like smoking or alcohol history. Also talking about the OCB that she has started or any other new medication that she might be taking and about their potential side effects. Although these breath holding spells are usually not very common with the OCPs, but still I would like to consider because they are the new drugs which are started. Then I would like to go on with the examination point of view that I would like to take the vitals, do a systemic examination, especially the upper respiratory tract and the lower respiratory tract along with the cardiac examination in detail to see if there are any positive findings that I can encounter with.
Right. So, Utkarsh, suppose you went to everything. Most of the what you told has already been given to us in the history also. But suppose after your evaluation is done, would you consider this particular setting to be that of a psychiatric problem or something related to psychogenic hyperventilation?
Yes, sir. Definitely, because it's given that X-ray is normal, echo is normal, so we have ruled out the possible respiratory and the cardiological causes. Then, moreover, these recurrent breath holding spells are common in the anxiety and panic attacks, and also because she has a history that husband is not there usually, and that may also contribute to her stress and anxiety. So I would obviously refer the patient to a psychiatrist for the holistic management approach for the counseling and the support, whatever can be done.
Okay. So Mahesh Babu sir, in this particular setting, Utkarsh has sent the patient to you, the newlywed bride. And now what would you say, sir? Is this something to do with her thought process?
It's a common issue actually. Recently, I had a similar case. Like the patient is newly married and the husband is on tour or working elsewhere. He visits once in 2-3 weeks or so. Again, here we have to see whether the patient is living separately or with in-laws. So again, living separately also, like she will be anxious because all this while she would be living with the family and now she has to live all alone. And if she is living with in-laws, like naturally husband is not there for her support. And in case there will be minor adjustment issues for any girl, any newly married girl. So because she has to adjust to a new family. So those issues I would look into it. And I mean, again, I'm a person like who doesn't jump on to use medications. I would again discuss with the patient and discuss about coping skills, basically, like how she has to cope with the situation and if there are issues with the in-laws, relationship issues, those issues I would discuss. And if she is found to have syndromal depression, what we call, only then I would add an antidepressant. Otherwise, I mean, she should do good with adequate amount of like ventilation, what we call, like allow her to express her thoughts or emotions. I mean, that itself will be therapeutic in most of these instances.
Right. So Suryakant sir, your final take, sir, करना क्या है ऐसी situation?
Actually, You have already done workup. Chest X-ray is normal, echo is normal. I mean, that is enough. So there is no respiratory problem that is corresponding to the breath holding episodes. So this appears, on my first sight, appears to be a psychiatry case, and I would refer directly to the psychiatrist.
Great, sir. Great. Okay. वैसे भी वो नाव में आता है पूरे बारातियों के साथ ही आई तो थोड़ा better to refer early. Right. So this I'm coming to another case scenario. These case scenarios are all actual, no make believe. Now I have with me again from Hyderabad, Dr. Nazia. Dr. Nazia, you are with me?
Yes.
Yeah. So now I have for you an elderly lady, a shopkeeper, who presents to us with persistent cough with no diurnal variation or association with known risk factors. Her physical examination was normal, basic investigations were normal, and she was advised conservative treatment for the cough. Her cough was persistent. She was advised to undergo bronchoscopy, endoscopy, which she refused. She went from me to you, from you to you to her, and a lot of other places. Ultimately, she was referred to a psychiatrist for psychogenic cough. There also, the psychiatrist prescribed treatment for her, but she had poor symptomatic relief. On repeated explanations and unko manane pe, she agreed for the endoscopy and she was diagnosed to have hiatus hernia. Now tell me one thing, she again comes back to you with cough. How would you manage this case?
This is a different case where we are seeing a patient of hiatus hernia, and I'm happy that finally she could diagnose herself that she has hiatus hernia. So now when it is a diagnosed case of hiatus hernia, we should, my workup would be to see what is the grade of her hiatus hernia according with the CT, like if it is a mild one like sliding hiatus hernia, or if it's severe which is having a esophageal, near esophageal involvement. If it's like a grade 1 sliding type of hiatus hernia, we have to go with proton pump inhibitors, and sometimes postural variation, like she has diurnal variation we see here. So definitely there is postural variation in her cough, because the pathological component is her gastroesophageal reflux, which is causing the cough here. So the proton pump inhibitors, her lifestyle changes, which can make changes in her caffeine intake and other spicy things and all, also can relieve her cough. And during sleeping time, she has to keep her head raised. And all these things are only if it is a sliding type of hiatus hernia. And if it is diagnosed case of after her esophagoscopy and endoscopy, it is a paraesophageal type which needs intervention, then we have to go for further workup. It definitely needs the help of a gastroenterologist. So that has to be managed accordingly. But as a pulmonologist, we can prescribe a longer course of proton pump inhibitors, lifestyle modifications, and postural changes. So that would be my mode of management for this.
I agree with you. Over here, Mahesh Babu sir, to matlab one down wale the. Already the psychiatrist was treating her for psychogenic cough, but then it was not that actually. So Mahesh Babu sir, what is your take on this? This is a case where the patient was referred to you for psychogenic cough, but actually it turned out to be an organic cause. So in these sort of cough cases which are not having leading symptoms, what is the psychiatrist's take, sir?
Yeah, it's a difficult thing actually. And here I would say that we all should remember a negative medical workup does not mean does not diagnose a dissociative disorder. That means to say dissociative disorder is not a diagnosis by exclusion. So both can coexist. But here again, because of the repeated visits, one would be tempted to treat it as a psychogenic. Again, as I have learned, in my earlier days, even if a patient comes with pain abdomen, it could be a TB abdomen. Repeated admissions like that, or the repeated complaints by the patient would force a physician to send to a psychiatrist. Again, I have learned that we have to reinvestigate again. So we should have a high degree of suspicion. And what I've learned is it is better to err on organicity side than on the psychiatry side. So again, I would be suspicious again.
So Suryakant sir, your final take is scenario mein, sir.
Yeah, I think this was the premature referral to the psychiatrist. So I think the Dr. Nazia has rightly mentioned that the GERD problem and the hiatus hernia problem, they have been considered for the persistent cough. Because we know that most of the common causes for the persistent cough are the postnasal drip, the sinusitis, and the GERD. And all they should be taken care of first, and then only we should refer to the psychiatrist. That is the message.
Right, sir. Sir, so now we have a few more cases. We'll just hurry things up a bit. I have our interventional pulmonologist from Hubballi, Govind, with me for the next case. So, Govind bhai, now this case is a very high-profile case I am sharing with you. A businessman has an income tax raid at his premises, and he develops shortness of breath with choking sensation. But he also has a history of bronchial asthma. He is a regular patient of ours. He is also obese and having loud snoring. He has history of alcohol consumption, tobacco consumption, and regular foreign travel. After the raid, he was served a non-bailable arrest warrant by the investigating team, and he developed a severe attack of shortness of breath. Immediately, you were sitting in the hospital nearby and you were called. So how would you work up this case?
Firstly, this case actually looks like a movie scene. So we have this business.
All these are actual scenarios. Believe me, nothing.
Yes, sir. Yes, sir. So looking at this case, let us go looking into a system wise. So he has a history of bronchial asthma. So number one thing is whether that stress, that the income rate, what has happened, has it induced an acute exacerbation of bronchial asthma is the first thing. That case, obviously the chest X-ray will be normal, but when you clinically auscultate, you are going to hear the wheeze, you're going to hear the rhonchi, and then you have to treat it in terms of that. Second, again, going to the history, respiratory symptom, there are chances of obstructive sleep apnea in this case. Whether that has triggered and whether that could be one of the reason of his choking sensation, we don't know. Quite unlikely. Third, history of alcohol. Now here, it's very important to know how severe is his alcohol dependence. Does he take a lot of alcohol regularly? We have heard in the forensic medicine when we used to read something called as café de coronary syndrome. In those cases, is it something that has he had food and suddenly has he had alcohol just before the income rate, and that led to an event of choking of food particle into a cardiac arrest is something which I would surely rule out. And last but not the least, could it be an acute myocardial infarction itself? Because again, there's a stress and that has led to an episode of shortness of breath, and either has it led to a cardiac arrest or a cardiac myocardial infarction presenting as a shortness of breath. So these are few things which I would surely rule out before telling that whether this patient is actually malingering, or before I actually inviting the psychiatrist in this case.
Right. Your point is very well taken, and that was how it actually turned out also. But Mahesh Babu sir, in this particular situation, like Govind hearing the history only told ki it's all filmy, ye to pakka kuch to gadbad hai. But I agree with organicity. Tell me, as a psychiatrist, is situation mein, what is your opinion, sir? What was that person actually faking it?
I mean, I would, with all due respect to the symptoms and ruling out the organicity, and seeing the VIPs being raided or our politicians being, whenever they are raided, arrested, I mean, they feign chest pain and get admitted to get they just get bailed out of it, and instead of being in the jail, they go to the hospital. Because I was visiting Central Jail here in Bangalore as well as in Davangere here. So where patients, as soon as they get admitted, if they are 50-year-old or so, they would feel chest pain and then get admitted to hospital, get investigated and all that. And then after all those preliminary things, we are called in. So I have had to see a few patients like that. After ruling out all these things, which we have to do customarily and mandatorily. So my strong hunch is malingering. Okay. And the sudden onset and the sudden exacerbation of these things should we should consider malingering. At the same time, take precautions as well.
Right.
And an acute anxiety as well. could present like this acute anxiety also we need to consider.
Right. So सूर्यकांत सर, इस वीआईपी का बिजनेसमैन का कुछ फैसला करिए सर, ये कहाँ रहेगा, जेल में या
Actually, definitely, you see, for our medical fraternity, patient is patient. He may be businessman, he may be rickshaw puller. Everybody needs our attention. So he needs attention. Yes, of course, he needs attention. He should be hospitalized. And suppose he is hospitalized under me, I will ask my resident to send a reference for the cardiology, manage if at all there is acute severe asthma. And of course, third, you also send to the secretary reference, because if it is the stress, which is the precipitating factor, either for the acute exacerbation of asthma or for precipitation of MI, in both cases, you also have to relieve the stress. So parallelly, I will send the references to all the cardiologist as well as the psychiatrist. And of course, same time, I ask my resident to evaluate for the acute severe asthma and manage accordingly.
Right. Perfect. Perfect. So this is abhi kabhi koi bhi VIP profile nahi hai. All patients are VIP. Evaluate them totally. That is the bottom line of this particular scenario. Now, coming to Utkarsh. Utkarsh, tell me, a middle-aged female comes to us with shortness of breath on mild exertion, chest tightness, and feeling of choking. Her husband is a chronic alcoholic, and her son did a love marriage. But the pair is living separately because of a dispute between the daughter-in-law and herself. Now, this particular lady, she underwent a sleep screen. And on the basis of the sleep screen, the primary physician advised her NIV. She even took an NIV, but she tolerated it poorly. She was asked to undergo a spirometry, but she could not perform it properly. She underwent an X-ray. It was perfectly normal. Now, how would you work up this case? Tell me.
Sir, I would like to know about the past respiratory issues about this patient regarding any allergies or the chronic illnesses. Then on examination, I would like to know whether there are any abnormal breath sounds or vitals or heart sounds. The classical differentials that I could find, I could make out is either it could be asthma that can also that presents usually with dyspnea on exertion, chest tightness, choking feeling. So I would like to consider that. I may consider a trial of bronchodilator with inhaled corticosteroids and observe for the response in this patient. Then dyspnea and chest tightness can also be related to cardiac issues. So I would go for an ECG and echo to evaluate the cardiac functions. I would also like to see about the past treatment records, like patient was prescribed NIV for some sleep issues. So I would like to know about them, and a polysomnography may be necessary to diagnose or manage this case for regarding the sleep-related any disorders. Then considering about family situation, about the chronic alcoholic husband and conflict between the son and the daughter-in-law. So this can obviously contribute to the stress and anxiety. So psychologist support would also be mandated. So overall, I would like to manage it in a multidisciplinary manner.
Right, quite right. So Mahesh Babu sir, this particular setting, any input from your side, sir? Did you think of any psychiatric illness in this particular case?
Yeah, I mean, this like the family pathology that we see in alcohol dependent patients. So alcoholics, if he is an alcohol dependent, there will be definitely strained interpersonal relationships, and which would which will definitely affect the spouse as well as the children. Children of alcoholics tend to have more of depression, things like that. So her son, again, we don't know, he got into a love marriage. Again, that would add this stress to the patient. And if it is an acute attack, of course, I mean, we have to rule out all these things and then consider treating the alcoholic. That is also important, as well as treat the underlying or the associated depression. Here again, we always should remember that both can coexist, the physical as well as the psychological. And in all these cases that so far that we discussed, what I see is none of these are histrionic. We should not label them as histrionic or conversion dissociative disorders. All these symptoms, the physical symptoms, are occurring out of the out of depression, anxiety, adjustment issues. So they are not outright dissociative symptoms actually. So they are all part of, there are symptoms part of depression or
Right.
anxiety.
Right. So ultimately सर सूर्यकांत सर आपके पास आए हैं ये, अब क्या सर क्या करें इनका सर अब आखिरी?
Actually, Ravi, there is a sufficient background for the psychiatric manifestation. If you consider her family scenario, as far as her husband is concerned, or son and recently married, the son separation and all these things. So there is a definite background, the family background, which is of creating a lot of psychiatric manifestation. This is the first possibility. Anyway, you have done the spirometry, but she cannot perform. You have done chest X-ray, which is normal. And there is a past history. Suppose there is no past history of any respiratory illness. And on examination, if there is no hospitacular breathing or bronchi, means there is no evidence of airway obstruction. And if at all she can do the peak flow meter, then you can assess the lung function by peak flow meter. Or if you have the facility of impulse oscillometer, you can do with the tidal breathing impulse oscillometer. And once you have ruled out any evidence, there is no evidence of bronchospasm, definitely this is a psychiatric case and she must be referred to the psychiatrist.
Perfect sir. Sir, अपनी बातचीत बहुत ही relevant है. How I can say that is Krishna sir has just informed that more than 1,000, actually 1,008 people are actually with us in this webinar, because I think this is a very, very common case scenario presenting to a lot of people. So I would like to congratulate all the panelists.
Congratulations to Krishna as well, and of course the Chess Council of India.
Sir. Now, Dr. Nazia, see, all the tough cases come to you. Now, a village punch has come to you all the way to Hyderabad. Now, he presents to you with left chest pain of pleuritic origin and minimal effusion of left side on the USG chest. Dr. Nazia, you are with me?
Yes, sir. Yes, sir. I'm here.
Yeah. Now, the effusion is not tappable, but the Mantux is positive. And in view of his old history of Cox and on radiological basis, he started on ATT. After a month, he comes and his follow-up USG shows absolute clearance. He only has some ATT-induced gastritis. 3 months down the line, every 3 days, this guy calls you up from his village, I am feeling very weak and my gastritis is not going. Should we evaluate further? Should you evaluate further? Now, you or the physician who was at hand told ki, nahi, theek hai yaar, you just carry on with the medicine and we will see. But he doesn't get satisfied. He takes multiple opinions, undergoes self-CT scans and health checkups at any hospital which is available. What do you feel? This patient, how would you like to work up? One very important point is, at times you also get information through his wife that he is having an abnormal fear of death. Now, how would you work up this case?
Yeah. In the history, it actually is a case of tuberculous pleural effusion, as we can diagnose even if it was not tapped. There was a past history of pulmonary tuberculosis and he presented with minimal pleural effusion, and it was rightly started with ATT. And also it shows evidence that the pleural effusion had decreased after this medication. Then we have a history of weight gain and also healthy appetite, which also gives a positive sign that he is not having any chronic disease, which we might be missing here. So, but his anxiety and his like we can say some hypochondriac feeling of having weakness and severe gastritis, which itself shows that he definitely needs a psychiatric workup. According to me, this patient doesn't have an organic disease, but he is worrying more about his health ailment that he might die. So it itself is a disease in certain individuals, that they have this apprehension of getting worse or getting some diseases which they don't know. So as a pulmonologist, we can see that he has improved in his tuberculosis pleural effusion. He has gained weight. He's having a good appetite, and we can rule out any other malignant conditions or anything else. And definitely his CT scans are normal. So I would definitely take a help of a psychiatrist for this abnormal fear of death.
Right.
And he has to be here.
Right. Very well said. So Mahesh Babu sir, in this situation, what would be your approach, sir? What is your take on it?
Yeah, as Dr. Nazia said, like if he is asymptomatic, but still he is continuing to take ATTs. So we should keep in mind psychosis drug-induced psychosis here. If he is having fearfulness, abnormal fear of death, that is one aspect. Like we should go for the drug-induced psychosis. Remember, that is one. Secondly, psychologically, that why is he continuing to take ATTs or other palliative drugs? Is that it's a fear again? So that fear may be it need not be psychotic proportions also. That it could be a normal fear that I have these things, I may die. So what happens to my family? This kind of anticipatory anxiety may be there. So that may be expressed as like abnormal fear of death. So when I would rule out psychosis, I would like to see if we take history of any other psychotic behaviors, like he may be having hallucinations or delusions of say reference or persecution, that somebody is talking about him. So I would like to have a more detailed psychiatric history. Yeah.
Right. So Suryakant sir, in this particular situation, sir, anti-tubercular पे है वो, तो आपका what is your opinion, sir? Anything more?
It's 100% drug-induced psychosis. No confusion, not at all. Patient, the opinion must be taken from psychiatrist. And if she's on, patient is on drug-sensitive TB, the drug-sensitive ATT, then of course INS should be stopped. So take the consultation from psychiatrist, and as per the consultation, you can stop the offending drug. And after within the stopping the drug, within 2 weeks, the patient will be okay.
Great. Very good. Very good. Now, Dr. Govind, again, I would like to call you in for a 58-year-old male patient with a history of severe COVID requiring ventilator support, and he recovered subsequently. He was on home oxygen therapy for an year. He presents to you after an year. He was lost to follow-up. He came because his family brought him to you. He presents with shortness of breath, ghabrat, and occasional cough. He presents with an ability to lead a normal life. He has rejoined his work, and he is also asked to be seen by you, by his boss, as the boss is concerned कि कहीं उनका best employee again sick तो ना हो जाए. On examination, his saturation is 89%. CT is suggestive of some fibrosis. His symptoms show good improvement with treatment. He uses oxygen at night. On his follow-up, he has progressive weight loss, loss of appetite, and his family says that he weeps easily and is quiet mostly. How will you work this case up? क्या लगता है आपको?
So there are three possibilities which I consider in this case. Number one is that he had a COVID, and after that there are CT findings of fibrosis. It's very easy to label someone to be having as a post-COVID fibrosis, but I would really like to go and revisit to the history and ask whether this patient had any shortness of breath or cough before the COVID, whether it's actually any ILD, which has been misinterpreted to be called as a so-called post-COVID fibrosis. So in such cases, it could be a CTD ILD, and that could be the reason of weight loss, loss of appetite, is the extra-pulmonary symptom of that particular connective tissue disease. Number two is that, was this patient put on any particular drug? These drugs most commonly which we see prescribed could be a steroid. Has that caused any gastritis, and has that caused the symptoms of loss of appetite in this case, as well as leading to weight loss, leading maybe the gastric ulcer, and then further causing loss of appetite and weight loss? That is number one. Number two, has he been put on any antifibrotics? Because even nintedanib and pirfenidone are known to cause a history of loss of appetite and weight loss. What I'm very difficult to fill the L in this case is his family says that he weeps easily and is quiet mostly. So is there any component of psychiatric ailment in this disease is something which I would really like to evaluate, and I would take help of my psychiatric colleague. So this is my take on it, sir.
Good. So Mahesh Babu sir, what is your comment on it, sir? Why is this person weeping so easily?
He was on oxygen therapy for 1 year after COVID. Did he really require it? I mean, I have not come across any patient post-COVID taking oxygen for a year or so at home. That itself, to me, says that the patient is anxious as well as hypochondriac. So he fears that I might develop COVID, or I might die, or I still have COVID. So that is a hypochondriacal thinking, along with anxiety. So if he so probably he did not require oxygen therapy for 1 year. I don't know. You are the best judges of that requirement. So maybe I would, on those lines, I would reassure him. I would counsel him. That reassurance from the pulmonologist or the physician itself would suffice, I believe. So if he continues to have anxiety, then we would add mild anxiolytics and antidepressants. So anxiolytics again we would use for a short period of time. I don't use it for a long time. So mild antidepressants might help him.
Right, right. So Suryakant sir, in this particular situation, what should we do, sir?
You see, Ravi, I agree with the both panelists that definitely there is an organic cause. Patient is having post-COVID pulmonary fibrosis. Patient is on long-term oxygen therapy, and these are the two regions the patient may develop the fear psychosis that my life has become hell. Now I have to live with the oxygen. So there is a precipitating factor is there for this fear psychosis. Number two, whatever the region, it may be the pre-COVID idiopathic pulmonary fibrosis or the CTD-ILD, whatever it is, idiopathic pre-COVID IPF or pre-COVID the CTD-ILD or the post-COVID pulmonary fibrosis, whatever it is, but patient must be on either on steroid or nintedanib or pirfenidone. So all these drugs, they have gastritis, they have the toxicity in terms of altered liver function. So definitely that's why patient is losing weight. So that is the reason why weight loss is there. Now we have to correct the treatment. We have to take care of the gastritis. We have to monitor the liver function. And of course, we have to take the opinion of psychiatrists because a lot of precipitating factors are there. The post-long COVID, number one, and dependency on oxygen, number two.
Yes, bilkul, sir. Okay, so coming on to our one more case scenario, Dr. Utkarsh, I'll involve you in this particular case. He's a young male in judicial custody. He was brought to the OPD at a government chest hospital with a tight security cover. Now, this guy had persistent cough. It was dry cough. He had low-grade fever and loss of appetite. His physical examination and basic investigation in the form of an X-ray CBC were perfectly normal. Now, Utkarsh, how would you work this case up?
Sir, because the patient is in judicial custody, I have two major differentials regarding this. One is there could be something kind of infective etiology, and secondly, because of the judicial custody, patient might be in stress and in the jail kind of scenario, he might not be able to cope up and would be not be eating properly. So, firstly, I would like to evaluate the patient for the organic cause. To know about the duration of his symptoms, then exposure to tuberculosis either in the past or in the form of any colleague or in family in past. Then I would also like to know about the environmental exposure to toxins or pollutants that could contribute to his cough and low-grade fever, and also about the high-risk behaviors like exposure to drugs or any unnatural sexual practices that may expose him to HIV virus. Another thing I would like to examine him for the pallor, icterus, clubbing, lymph nodes, about the upper and the lower respiratory tract involvement. Though the investigations are normal, and if any finding is not there, I would still like to repeat a TLC, some inflammatory markers, an X-ray if possible, and while assessing all these possibilities, if everything comes out to be normal, then I would like psychological support for this patient.
Okay. So Mahesh Babu sir, in this particular setting, a young patient with persistent cough in the jail, would you find any psychiatric part that we can take care of in this condition?
Yeah, again, if there is no organicity, so we should again go for naturally anyone would have adjustment problems living in a jail. If we have seen our jails, we should see. It's very difficult to live there. So one is the adjustment issues will be there. and we have to see why he is convicted. So the background of the conviction also. Psychologically, like again, if there is no organicity for these things, so we would consider it as malingering. So again, even though it is malingering, as somebody said earlier, like we give a report of those things, and then the court will decide that he is malingering. Actually, to tell you an interesting case, if there is time for a minute or so, in my graduation days in Nimmans, a person had hijacked the aeroplane from Delhi to like that was in 1993 or so. So he hijacked it just to come into the fame. He was admitted in Nimmans for about 2 months or so. So we had to examine him, serial mental state examinations. Then we reported him as malingering. He was convicted, put into jail again. So, so that part has to be done carefully again. So if there are definite psychological issues, this person has to be counseled regarding coping. Because once we, as psychiatrists, label him as a malingering, it will be a difficult case for him. It goes into a criminal case. So very difficult to get out of it. So if he's really depressed, it help him to cope up with the situations.
So Suryakant sir, in such situations, please guide us. ये बहुत ही sensitive situations रहते हैं.
Yeah. Actually, Ravi, the patients in the jail, in the custody, they are vulnerable for 3 important diseases. Number 1, HIV. Number 2, TB. And number 3, the psychiatric illness. So I think we have to investigate, we have to do workup to rule out the HIV, to rule out the pulmonary tuberculosis, as this classically presentation is, of course, the pulmonary tuberculosis also there. Patient can mimic any problem, but cannot mimic the documented fever. How can he mimic the documentary fever? If you have the documentation of fever, which is more than 99, so fever is there, some organic cause is there. So I think we have to rule out the organic cause. Concomitantly, there can be some psychiatric problem also. And as Dr. Mahesh Babu has rightly mentioned, that we have to know for what he has been sent to custody. So that may be the precipitating cause. So I think we have to rule out organic cause, and same time, at the simultaneously, we have to also consult to the psychiatrist.
Right. Very right, sir. Thank you. Because at the times, even as residents, we are often lost when such a patient police वाले लेके आते हैं in हथकड़ियों में. So we also get wondered कि यार कुछ भी लिखेंगे तो ये क्या लिखे तो क्या लिखे आखिर.
So Ravi, there is a short story. One of my resident was working up 10-15 years back, and patient was with हथकड़ी. So he said, "I want your history." बोला हिस्ट्री मेरी बहुत खतरनाक है, जरा बच के रहना. So such kind of scenario they can also arise with such type of patient. Anyway, last case.
So last case, sir. This case I will be discussing with Suryakant sir and Mahesh Babu sir only, sir. This is a 20-year-old unmarried female with a conflict in her marriage proposal. She has a dry hacking cough for 1 year. She was sent to the chest physician by a physician due to poor relief in her cough. The physical examination and investigations till date are all within normal limits. So I would like to begin this time with Suryakant sir. His particular situation mein, what would you advise, sir? As chest physicians, kya karna chahiye?
Yeah, actually, you have to take the proper history, because this is the era where the affair and later on the breakups, such kind of things, they are very common. Marriage proposals, then of course the breakups, they're very common with the young, of course, people. Not only male, not only female, they are common with the males also. So both ways they can occur. And dry hacking cough for 1 year. I don't know what was the marriage duration of marriage proposal, and then of course the conflict in the marriage proposal. So if this coincides, the story coincides with the marriage proposal and then conflict, then of course we can think of the non-organic cause, means the psychiatric cause. Otherwise we can think of some. So I think we have to rule out all causes of dry hacking cough. So we have to rule out the sinusitis, the postnasal drip, the GRD, and other causes of dry hacking cough. And then of course we have to take the help of our psychiatric colleague also, and accordingly we have to manage.
Okay. Thank you, sir. Now, Mahesh Babu, sir, please would you guide us, sir, in how to manage this case?
Yeah, this is a girl like who was treated for nearly a year for cough. But here is where I would emphasize that physicians should consider the temporal correlation of the symptoms. And of course, you need to investigate. Not that you should not investigate. You need to understand the temporal relationship of the uh, symptoms also. So that you can refer the patient early. What happens is so many times I see patients being treated for 80 years, 5 years or so, without being without considering the psychiatric diagnosis or the psychological aspects. So such patients, when they come to us, they improve very rapidly, because any untreated psychiatric patient, if he is given proper treatment or psychotherapy, they improve dramatically. So that is where they say, I mean, sir, I lost so many months or years of my life. So that is where the history taking by the physicians is utmost important, so that an early psychiatric referral may be done. So this is one such case in point.
Right, sir. Sir, thank you. Now, these case scenarios were all actual case scenarios. Few were mine, few were from my colleagues, and few were of sir. Now, Mahesh Babu, sir, we are very privileged to have you. Sir would like to speak for us for a few minutes on some common psychiatric issues which he comes across in his practice. I will just start sharing your presentation, sir.
Okay.
Sir, please go ahead, sir.
Yeah, I mean, this is actually, I would be again talking on conversion disorder only, so-called, I mean, dissociative conversion disorder. I thought that this is an opportunity for me to psychoeducate our medical fraternity regarding psychiatry, awareness of these things. So I just have a few slides on dissociative. So dissociative conversion, like it's basically there is and loss of or partial or complete loss of normal integration between memories or the various domains of the brain, like memory and identity of the self and immediate awareness of the sensations or about the environment and the control over our bodily movements. Okay, so that is basically the concept of dissociation. So can I have the next one, sir? So here again, the common presentations that we see here are the hyperventilation, cough, and dyspnea. That is because now I am with the pulmonologist. I have highlighted those things. We routinely see seizures. Seizures are unable to move a limb or unable to see or unable to sense particular part is numb like that, or not talking for an year or so. So convulsions. Then we have amnesia, forgetting. Possession states are very common here. That they're possessed by an evil spirit or the soul of somebody or God. Those things. So clinically, like next one. So again, as I said, like we need to consider these are the general considerations where we all would be benefited to know these things. The sudden onset and termination of symptoms and their correlation to the stressful event. That's very important. Again, history taking is very much important. So the symptoms may last for hours or days to weeks, and again for a year or so, because if the conflict is not resolved, again the age of onset is usually adolescence and early adulthood. Elderly, again, it is very rare. In the very young children also, again, the dissociation is rare. So again, okay, next we can go. Next slide. Sir, next slide. Okay. So detailed history is of utmost importance of the present episode and the past episodes if they have had medications or drugs of abuse, substance abuse like alcohol, other drugs. Family history is also important, and the pre-morbid history, that prior to the symptoms, what was the person's personality, that is also important. Okay, so next slide. So I mean, investigation. That is, I mean, since I first consider the neuropsychiatry, like brain, I would go for an EEG to rule out seizures. Either hyperventilation or sensations. Again, I would like to rule out EEG seizures, actually. And then brain imaging, drug urine for screening of substance abuses. And the routine this thing, and serum electrolytes are, especially in elderly people. Prolactin levels again are raised during the seizure attack. And other relevant tests as the symptom may warrant. Like they come with dyspnea, you do with the chest disease related investigations. Right, sir. Again, the key general principles of management are when most of these patients we see acutely. Very chronic, repeated episodes, such cases, they come to us rarely. When they present to us, they are in an acute state. So there again, these things are important to ensure safety of patients and others. And we need to keep in mind that avoid confronting the patient, saying that this symptom is psychological. Again, it would, because of the taboo attached to these things, and the patients or the relatives may not be convinced of these things. So that confronting should be avoided. And we need to use the investigation judiciously. Over-investigation and more emphasis on the symptoms will actually help the patient to fixate on the symptom. And it may make them hypochondriacal, or definitely have some illness also. So the investigations have to be used judiciously and justifiably. So again, as I said earlier, diagnosis of conversion disorder is not by negative medical workup, as both may coexist. So we need to consider some things. So I think the last slide. The treatment again with the symptom removal is more important in acute phase, where we do it through suggestion and or placebo medication, or suggestion along with a noxious stimulus, like we give an injection or this thing, mild shock like thing with our ECT machine. There is one thing. Ectonus stimulation, what we call. Then allay the anxiety of patients and relatives, evaluate, that is the next stages. Evaluation for stressors, depressive features. Later, psychotherapy and psychotropic medications will be useful, as well as family counseling again is more important. Right. Okay, so I think the last slide one is there, where there is dissociation and malingering. So that comparison is there.
Right. So now, sir, Dr. Jayaraman from Chennai, thank you for this very excellent presentation, sir. It gave us a broad overview of how to approach these cases. Now, Dr. Jayaraman from Chennai, one of our CCI fellow members, he is asking us about the several tobacco cessation advices, nicotine replacement therapies, vernacyline. So are these still in practice, sir? Are you using them for smoking cessation program?
Yeah, these are like the tobacco patch, what we have, and these things. Again, as Dr. Ravi, Dr. Surya Kant highlighted earlier, smoking is most addictive, and it is again one of the most difficult one to quit also. Somebody can quit cannabis or heroin or those things, alcohol. Smoking is one very difficult thing to quit. Again, here I emphasize more on the psychological framework of the individual and the decisions, the commitment to the quitting program that he attaches. That is more important. Drugs, again, I have seen, many of these drugs are not very much useful. Again, the relapse rate is very high in smoking. We use like bupropion or tobacco, the nicotine patches or other agents. Again, the relapse rate is very high. Right. So the psychological inputs are more important.
And motivation and will to quit is very much important. That is a very, very relevant point. Now, the non-pharmacological causes, Govind, you had presented, and in that one, Dr. Manju from Maharashtra was asking out mitral valve prolapse. So is mitral valve prolapse is another very important hidden cause? आपने देखा है कभी इसको?
Very rarely, sir. My experience is very short. But yes, mitral valve prolapse can cause palpitation and chest pain, and it should be ruled out. Actually, sir, wo jo pehla case tha, in that case, also one more thing from a cardiac point of evaluation was getting a 24-hour Holter done. Maybe there are some blocks which might have not been picked up on an echocardiography or on an ECG, which could be more of a static study. Yes, mitral valve prolapse and other things can also be a cause of palpitation and chest pain. But normally, they also have a presentation of syncope, which is a very classical feature in mitral valve prolapse.
Okay. Okay. Now, one very interesting thing for our 1,000+ audience, we have actually crossed our normal limit of our discussions. But today, I think we have had a very good discussion and a very important discussion, because all of these are real case scenarios which in our pulmonology OPD we have seen day in and day out. So, before concluding this webinar, I would like a ending take-home message from all of our respected panelists. I would like to begin with Mahesh Babu sir. What would you like to give us a take-home message for us chest physicians?
I would, at the outset, I would thank CCI and Dr. Krishna to include me in this panel. And I think it's a very relevant topic to consider. So the take-home message is the coexistence of the psychological aspects as well as the physiological or the physical illnesses has to be kept in mind always. And as I said earlier, to err on the organicity is better than to err on the psychiatric side. So first, the evaluation is more important, because I keep saying that nobody dies from a psychiatric illness unless it is a suicide. And the patient goes into severe depression and commits suicide. They don't die of even alcoholic dependence syndrome or nicotine, heroin, whatever addiction. They may die out of complications because of those drugs.
Right, sir. Golden words, sir. Golden words to err better on side of organicity rather than psychiatry. Very well said. Suryakant sir, are you there with us, sir? Suryakant sir? Okay. So, closing remarks from Nazia ma'am. What would you like to say?
Very rightly said by Dr. Mahesh Babu sir. It's very important that first we have to rule out the organic cause before labeling it as a functional or a psychiatric disease. We should not miss any system like mentioned by respiratory, cardiac, or any, even nervous system or any other malignancy and all. Definitely when and there is no harm in taking definitely we have to go for a psychiatrist's opinion when it is needed. It's no harm in taking a senior's opinion or other specialty opinion. Thank you, sir. Thank you for giving this opportunity to me.
Right. Dr. Utkarsh. Mute. You are muted. Unmute yourself.
Yes, sir. Am I audible?
Yeah. Final. Take a message.
Yeah.
You're audible.
So I would like to say that we have to keep a holistic approach during investigating our patient and then towards the management. That should include the stress reduction techniques, emotional support, and empathy towards the difficult time of whatever the sufferings or the patient is. Even if he or she is malingering, there is somewhere a cause for that malingering also that should be looked after and should be considered for the overall well-being of that patient. Thank you.
Thank you. And Govind, from you, your take-home message.
So my take-home message is very important. Is that as a pulmonologist, we always focus on the chest and the lungs. So there are symptoms of breathlessness, cough, and there are reasons for that other than the lungs. So that is number one. We also have to look for the extra-pulmonary causes. Number two is that whenever we are stuck with any clinical features after investigations, we are not able to get to a diagnosis, always let us get back to the history. Sometimes we do miss out something in history, and that might actually help us in getting back to a diagnosis, a firm diagnosis.
Right. Thank you. Now, sir, final concluding remarks from Suryakant sir.
Yeah, Ravi, thank you very much for this wonderful opportunity to be part of this very important webinar. Actually, Chess Council of India, and especially its originator, Krishna, always come with very vibrant topics. And that is the success of probably the webinars that more than 1,000 people are logging today also. You see, what kind of practice today is going on. So I would compare this practice with the 3-storied house. The ground floor, the first floor, and the second floor. The ground floor is the MBBS or the GP or the family physician. Your background knowledge of MBBS, the first floor is your specialization, and second phase is super specialization. Now, whether you are living in the second floor or on the first floor, but remember, if you are not having a strong ground floor, you cannot flourish. So the message is very loud and clear that your MBBS knowledge, you don't forget it, and you make a very sound knowledge. And whenever you find the time. Please get a basic knowledge of all other specialty also. Don't have the tubular vision. You are a pulmonologist, no doubt. You are a chest physician, no doubt. But if you just forget the other specialty, you will forget to give the correct and, of course, the sound kind of prescription to the patient. Right. And ultimately reach to the patient. So always thinking of other specialty, correlation with other specialty, timely refer to the other specialty. So that is the message for this webinar.
Right. Thank you so much, sir. So ultimately, I would like to sum it all up, give a big thank you on behalf of CCI for all of you wonderful, our respected senior panelists, Dr. Mahesh Babu, sir, Dr. Surya sir, who have shared their wisdom, and extremely, I would say I'm really thankful for you for sparing your time today. I would like to give a lot of thumbs up to Utkarsh, Nazia and Govind, who have spared time for us and have put in a lot of effort for making this webinar a success. So on the behalf of CCI, myself, Dr. Ravi Dosi from Indore, I would like to wish you a good night and hope to see you next Thursday for our next weekly webinar. Thank you.
Thank you.
Thank you to all. Okay. Namaskar.